Hi, so I'm from Salford and I led the pilot on e-cigs. So it was again just to, obviously we've done the pilot, we've got some great results. We ended up tackling groups that we hadn't previously been, we found very difficult engaging to giving up smoking. But I completely empathise with the lady at the back that actually we don't want to shift those norms that we've managed to actually shift now. So I suppose it was around what is the next steps for GM? Do we have a collective position on this, or is it down to localities on how we take this? Because I think what we don't want to see that gateway into the young people, and the clinical and the public health community are split on this.
So thank you for your comments. Sorry, I didn't catch your name, the lady at the back. As a frontline clinician, I share some of your concerns. So in my 20-year career as a GP, I've seen two things make a real difference to smoking levels. The first was the 2007 ban in public spaces. The second is the introduction of vaping, which is increasingly seen by my patients as an alternative to smoking and as part of smoking cessation. And obviously the Salford pilot is extremely impressive, much higher quit rates than any other interventions that have been available over the last 20 years. But what we don't know is the full safety implications of vaping, and there's been some recent studies. The University of Birmingham only very recently said it targets immune cells in the lungs, which can lead to the same level of damage as you see in COPD. So what we need as frontline clinicians is robust data and evidence from Public Health England. So Public Health England currently states it's less than 5% the harm of smoking, but we're seeing more and more studies coming out to the contrary, and we're also seeing normalisation of vaping because people are seeing it as socially acceptable. So you know, I'm looking at Public Health England colleagues for guidance here. So Gillian, I think one of the things we need to do after today is think about how we can get accurate messages out to frontline clinicians so that when people come to us to ask for our advice, we have something sound to say to them.
Thank you. I suppose just echoing on from that, I think we had quite a robust debate at our Health and Wellbeing Board in Manchester around e-cigs, and I think it's fair to say there is a lot of division in opinion out there on where people sit, and I think the point at which we came down on it is that we understand that in terms of harm reduction, there is a discussion to be had there about the use of e-cigs, but it's not reducing harm completely, and it's in some ways quite similar to discussions we have perhaps around public health debates and drug use, around reducing harm rather than eradicating harm, and being very clear on that. The point I was going to make was slightly different. First of all, I was going to thank you for sharing your personal story. I think it was really great to hear from you, and keep up that running. We can only look at you with envy as you're completing those half marathons. The bit that I wanted to touch on briefly was one of the things, I'm not easily shocked, but one of the things that shocked me probably most recently was in Manchester around our statistics of smokers, and that 49% of people with COPD were still smoking. And I think that to me really highlights the need for a much more coherent and joined up approach, not just in terms of public awareness, but some of the other things that are covered in this paper. So for example, the rollout of the CURE programme I think is a really good step in the right direction around the access to services people will have when they're in acute care. That also leads me on to the point that was referenced around potential opportunities at 3.11, which is around talking about smoke-free spaces and the discussion that we have around mechanisms that we could use for that. Obviously, Manchester City Council is cited in there as being the lead, but to be clear, that would be with and for Greater Manchester, and that we as a whole within the partnership would need to collectively sign up to the notion that that's the direction that we want to travel, and that would be kind of met within a GM context with Manchester taking the lead. So it's a flag that those discussions are indeed ongoing, but it's for and with rather than independently. But to me it makes perfect common sense if we're rolling out high cost interventions in hospital care, but those people are having to walk through smokers on their way in and their way out, then we're not going to be able to join up the dots in any coherent way.
just to summarise, thank you, very helpful points, and we'll take them into the Population Health Board, particularly on the e-cigarettes. We are looking, obviously, Public Health England in terms of guidance. Interesting, we had a motion from our Youth Council recently at Oldham about the flavourings and the promotion targeted at trying to encourage young people. So there are certainly things that we could do across Greater Manchester to target those aspects. So thank you for the discussion.
To move on to the urgent care improvement plan, I think, Anthony, you're going to take this one.
Yes, thanks, Chair. Anthony Hassel, Chief Officer at Salford and at Trafford at the moment, and I'm just presenting this paper on behalf of the Greater Manchester Urgent and Emergency Care Delivery Board. There's a paper in your packs. I'll assume that you've had an opportunity to read that. Andrew Foster's sitting behind me. He, with myself, co-chairs the Improvement Board, and I think that sends a signal, importantly, about how we're trying to approach the challenge of urgent emergency care in a different way this period, by ensuring that we have system leaders absolutely involved in leading this improvement and collaborative effort. So why do we need to get this right? This is really, really obvious, and I don't need to rehearse it for everyone. But some of my own personal experience, some of you will know that I often talk about my mother-in-law, Joan. Luckily, she hasn't been through A&E recently, but my mother, Margaret, who has recently moved to Salford, was actually admitted to Salford Royal on the 2nd of January this year. And whilst she had fantastic care, it was clearly a very challenging environment in which both patients and families and indeed staff were operating, because just of how busy the department was. And clearly, of course, what that says to us is we must ensure that systems and individuals and teams are working together as hard as they can to make sure those patient experiences are maximised. So what we've done, we've created a Greater Manchester programme, but which really does intend to add value to the work that is going on in localities. It's clear and obvious that it's teams in localities that are the best placed individuals and areas to know how to deliver and to know how to improve. But it's also clear and obvious that there are common challenges and common areas where we can work together to improve and in a very patient-focused way. The other thing that we've absolutely tried to do is to ensure that this is connected strongly to both locality plan improvements, the work that's going on around transformation, and that this feels like this is one plan as opposed to a separate plan around urgent care improvement. And absolutely ensuring that this concept of patient time is the most important currency that we use in health and care. So what we've done is through a strong process of engagement, both with clinicians, frontline teams, as to what would add value, we've identified 4 work streams that we're now running with at a Greater Manchester level. And these are work streams where we've identified that operating at a Greater Manchester level, learning at a Greater Manchester level, collaborating at a Greater Manchester level, we can really help individual locality systems to improve. And so under each of the 4 work streams, we have identified a number of areas, and particularly what we're trying to do here is identify best practice in localities. So for example, we know in Stockport and Trafford, really strong uptake of flu vaccination. How have they done that? Where can other localities learn? Bolton doing some really interesting stuff around supporting nursing and residential care homes. Wigan and Bury doing some fantastic stuff around patient flow and improving that. And in Salford, some really strong work around discharge and recovery. So how do we ensure that each locality is learning from the best of each other locality and driving that forward? And you will have heard again me say this, but one of the things that we want to be really clear is, does this programme pass the Ronseal test? Does it do what it says on the tin? How does it do is it delivering the improvements that we need it to across our systems? We know and expect that the winter will be a challenging period, and indeed many would argue that we now have a year-round winter. So what we are wanting to do is to ensure that we collect data that is sensible data, that is data that's already collected, so we're not looking for new data, that enables us to measure and inform how our systems are operating, and indeed, where possible, to predict challenges in systems. So just a couple of examples there of the data that we'll use. And then how are we driving this? As I started this presentation, this is all about this being led from the system with strong clinical and officer engagement from all different parts of the urgent and care system, and absolutely connecting into those locality-based transformation plans, but also accessing that improvement expertise that we have available at a Greater Manchester level to give us that professional advice and guidance. So in terms of next steps, we know that the next period will be a challenge. Clearly, it's important that the improvement programs that we have in play start to have an impact at a locality level in terms of the improvement needed. I'm confident we have all parts of the system engaged, but also that we are adopting a clear improvement focus. Indeed, Andrew and I will be present at a system development workshop that we're holding this afternoon in Salford, where all parts of Greater Manchester system are coming together to ensure that we're aligned on this work programme. Thank you.
Andrew, do you want to comment?
Just 2 points to support what Anthony has said. I think that this is a very well structured programme this year, and there has been a huge amount of learning from each other, and it actually exactly matches onto the national programme for improving action on A&E this year as well. The feature of A&E is that the metric is the performance within the A&E department, but actually that is the product of how a whole system works. And the two things that I want to say in addition to Anthony's is that we have quite a focus on A&E delivery boards. Each locality has an A&E delivery board which is managing the entire system. And we want these A&E delivery boards to be as effective as possible, which means taking ownership of the problem as a system one, which means having the right people on it, having all the agencies represented, and concentrating the attention of that board at the right level. And that's what this afternoon's workshop is substantially about. So that's that point. The other point is what happens during times when things are difficult. And those of you, well, many will know that from January to March this year was some of the toughest times we've ever seen in A&E departments. And I think we have to be very careful about the interventions that take place during those times. Certainly issues like data collection and requirements for reports are something that have to be handled very sensitively when the people that will be providing that data and managing the situation are as pulled out as they were last winter. So that again is something that the board will be looking at this afternoon.
Sorry, thanks. The work that you've been doing on that obviously seems good, and fingers crossed for the coming months. Moving on then to estate strategy. You say that from there, John.
And we did have some slides, but to save time, I'm actually not going to use slides. I'm going to just speak to the item. Before I do, I actually just want to interrupt the agenda to do an advert. Because I should have done this in my Chief Officer's report. I meant to, and it slipped my mind. But today, James Frith, MP, is publishing a really important report, and it's a really good report as well, called Living Well and Dying Well. And it's basically about hospice care. And it speaks really about Greater Manchester and the provision and use of hospices in Greater Manchester. But actually, I think it's got implications for the whole country in terms of the role of hospices within our palliative and end-of-life pathways. And the report will be launched today, and it's already available on social media, and it makes a whole set of findings and recommendations. I think it's brilliant that a local MP has stepped up in this way and done this almost in extracurricular piece of activity to such a deep level. And the findings and recommendations deserve to be taken very seriously, and we will take them seriously and respond to them in due course. But I just wanted to bring that to your attention. So back then to the agenda item. I don't know how many of you have been watching the Great British Bake Off so far. If you haven't, then bear with us, because some of us are still recovering from the tension of Bread Week. No spoilers, no spoilers. For those who are watching on catch-up, the bread is still rising. But there's a character on it, one of the contestants called Rahul. And Rahul's amazing. It's worth watching. It's worth watching the program actually, just to watch Rahul, because I've never come across anybody who's quite so pessimistic about everything, and yet he's a genius chef. But the danger of this item, and the reason I make the analogy, is that there's a danger of coming across as very, very pessimistic with respect to the state of our estate and the amount of work that needs to be done. And I wouldn't want to lose in that, because I do need to be realistic with you, the fact that we are also very determined to have a really great plan of how we're going to make progress in terms of improving that estate as well. We're bringing this item here today because we were asked, every STP, Sustainability and Transformation Planning area in the country, was asked to develop and submit an estate strategy to the national bodies and to government, which placed us in a bit of an odd position because we already had one. Under devolution, we'd already prepared one bottom up from our 10 localities some 18 months ago. So anyway, we took the opportunity to refresh it, which was not a bad thing to do, and to make sure that it was up to date, fit for purpose, and could underpin our bidding processes for individual pots of money to deal with individual project requirements. I think there are some things that are very distinct about how we think about estate in Greater Manchester compared particularly to the rest of the NHS. The first is we do genuinely take a whole public service estate perspective. So we don't just think about the health estate in isolation, not least because actually many of the buildings, particularly those in the community, are multi-use anyway, and so they should be in terms of the integration of services and the alignment. But the second is that we do genuinely build our estates plans and strategies bottom up. So we have 10 locality estate plans, 10 locality estate boards that are doing that coalescing at the local level, and then obviously we need to make sense of that at a Greater Manchester as well. Which brings me to my sort of Rahul point, which is that the reality is that when we took charge in 2016, part of taking charge in terms of our legacy was of an estate that has been, well, grossly underinvested in over the last decades. And moreover, there is a variation, which means that the estate which is in the poorest condition is in our poorest communities. Now we might ask ourselves, how on earth did that happen? Over those decades, how did we collectively end up in a position where, particularly in terms of our NHS estate, the estate which is in the areas that suffer from the worst health and have the most need for those services have got the worst estate? And that is concentrated, not exclusively, but significantly in the estate of Pennine Acute NHS Trust. And I'm not going into the detail of that today, but I state that as a matter of fact. So the reality is that we have a large backlog in terms of routine maintenance and repairs that we inherited, and we have a major need for replacement and upgrade of a whole range of buildings, both within the community and within the acute estate. We're also, it has to be said, hamstrung to some extent by the way that the health estate has been developed over the last 2 decades, and not least through the use of private finance mechanisms, PFI, LIFT, which ties us in to particular long-term deals, which can make it more difficult to actually flex the way that we use buildings and organise services for the best benefit of patients. But that is our legacy. We own it, and we have to accept and make use of the asset that we do have and the constraints in terms of we're operating under. Within that context, we take a very flexible approach to capital financing. One of the benefits of being a partnership is we can think about what everybody can bring to the table: government, central government, local government, combined authority within that, obviously the NHS itself, not least through the trusts, and within that particular freedoms around the foundation trusts. But the bottom line is that if you look at our need for resource, there will always be a significant reliance on public service capital. And one of our asks of government, which will be embedded within our target operating model ask, is that we should be given more freedom around how we use public service capital. So instead of having to bid for every individual project and that being decided in Whitehall, that actually we should be given our pro rata share of capital resource going forward and should have our own ability to determine the best way to use that and to combine it with other funding sources with respect to one public service estate. There are needs at community level in terms of our integrated care model. There are needs at the acute level, and we're doing master planning at most of our sites to make sense of our legacy. And there are particular opportunities around our mental health estate in terms of dealing with buildings which are really beyond fitness for use, but also consolidating some of our offer into better buildings, better campuses, better service opportunities. In all of this, as we go forward, we need to be mindful about what the population want and what they need. And we should be driven really by two main objectives. One is improved outcomes for people, particularly clinical outcomes and benefits. And the second is the ability to actually get to those services, in other words, travel, and particularly thinking of those who do not drive and are reliant on public transport or may have mobility restrictions. We also need to get our own house in order. We can utilise our estate better. Our utilisation rates are not as good as they should be by some distance, and we need to make sure that we are making the most of our buildings. The second is that where we can release land, we should do so, not least because we can use it to build homes. And they could be key worker homes, they could be affordable homes, they could be new supported housing, they could be intermediate care facilities. And we can potentially bring that to the party. So I hope that's a useful summary of where we are. I think we've got a good plan, a good strategy. I can't say hand on heart that we know how all of it's going to be funded right now, but we know what we would like to do. We know roughly the order in which we'd like to do it, and that's a good place to be.
Thank you, John. Any questions, comments on that?
Thank you, Peter, and thank you, John. Very comprehensive update. Just want to come back to your comments about the lift estate, and I recognise the point you made about the contractual difficulties. But I'm kind of guessing here, but I think it's probably not far wrong that average utilisation of lift buildings across GM probably runs about 60%, maybe 70%. Some better than others, but there is capacity there. It is modern public estate, and it's in the heart of communities. And actually, it's a place where huddles, the place-based teams, should really, it's an obvious location, isn't it, for that work. I just wonder, is there something we could do to either buy out some of those contracts, or as they expire, have a policy where we increasingly bring that estate in to the public realm. I just think it is. Some of it was built, I think, from memory, about 15 years ago, in the early part of the last decade, and maybe some of the not as long as PFI contracts. Some of them may be expiring. Is there a case for a bit of a piece of GM-wide work? Is it Partnerships for Health? I think they were involved, weren't they, as well, to see if there is a deal to be done, maybe not on a case by case, but more if there's similar players working in all 10 boroughs, maybe there's a conversation that we can have a scale rather than an individual building level. I just think it's an issue that is something that at some point we need a better solution, I think, than the one we've got. And actually, if we did manage to gain control of some of those buildings, there is a an efficiency opportunity there, isn't there, by consolidating people within those places. So just I think something I've kind of kept thinking about and wonder whether the scope for a wider GM-wide solution.
To that. So first of all, we would share your ambition. We would like to get control of those buildings in terms of being able to use the estate more flexibly. I've sent your office a technical note as to why that is so difficult at the present time. And it is to do, without going into the great detail, it's to do with the way that the lift contracts were set up and the use of swaps as a financial instrument in terms of underpinning those deals. And basically, related actually to the financial crash 10 years ago, it has become prohibitively expensive to buy out those deals in terms of justifying it on a value for money basis. In other words, the swap has gone in the wrong direction in terms of anybody looking to buy those contracts out. I'm very happy to make that technical note more widely available. There's no secrecy around it. But I think we need to do two things. One is watch very carefully to see if at any point those market conditions change and it becomes a more affordable proposition. And the second is, as you've already said, is as those deals come to an end in terms of the period, make sure that our relationships with Partnerships for Health and others are such that we get the right outcome at that point.
Any further comments on John's report? For the Stark information, you said that the worst buildings are in the areas of highest need, so obviously that we will need to address. Okay, thanks again, John. So then we move on to our final item, which is Rochdale story. Who's going to say?
Thank you. Hello, I'm Karen Kenton. I'm Associate Director of Commissioning across Health and Care here in Rochdale. And what I'm going to give you just now, I'm conscious of time, so it'll be a very quick snapshot of some of our transformation schemes here in the borough and some of the emerging evidence of impact that we're having. So what we really, when we think about transformation, we often think about really, really big things, big system change. And up there you've got a couple of diagrams that I'm going to talk to you quickly around family services model, which is some of our transformation schemes around children and young people, and then our easy hubs, which is the purple bit. What we really quickly realised, and being the home of cooperation in Rochdale, no charge, that the things that drive transformation are often the little things, and I think Donna from Wigan's already alluded to this, and it's much more around how we cooperate and connect that's going to lead us to improving outcomes across the borough. These are just a few examples of things that are happening in the borough. So our heat car, so basically that's a car that instead of when the call goes into MWAT, instead of an ambulance response, it's a car that's staffed by advanced nurse practitioners and emergency medical technicians, and those calls will be triaged and an appropriate car will be sent out. There's a quick scenario there for you of how that's working. In terms of early impact, we're seeing 71% of those calls don't then go into attend emergency care department, and 24% of those avoid a non-elective admission. So some really encouraging deflections there. Primary care focused care workers are folk that are based in 32 out of our 36 GP practices, and they're really offering an enhanced support to our GPs to manage those complex patients whose needs are often not necessarily health related but have got a multitude of social wider determinants of health. And since April, around 384 with people have been supported in that way to really improve the capacity that we've got in primary care and to free up some of our GPs' times to focus on the patients that they really do need to focus on. Our easy hubs, these are some of the problems we were trying to face, and it won't be Rochdale will be no different. What our residents were telling us, and our workforce, the system is really difficult to navigate. There's far too many entry points. There's loads of information and advice. It's not cohesive. It's not come together. The solution is obviously face-to-face access and a single point of access that the general population and our workers know where to go to, with the big focus on solving some of these big goals that we think are critical to why people fly around the system. So connectors provide information, advice and signposting across the whole system, so voluntary community sector as well as some of our more statutory provision. They are based in each of our townships through one of our live centres in one of our areas. Some of the real learning, our community connectors, we've got 12, did I say 8 or 12? But they were all recruited from the local community and are all people that have got real life experience and have experienced some degree of adversity in whatever throughout their life, so can really connect with people and have a lot of credibility with our service users. They've been up and running since May, and so far have supported 450 people to access a vast raft of services across the borough. And the bottom square in the screen is our One Rochdale, which is a integrated services directory across the borough, so that they're helping local residents to navigate that system and to use that system in terms of finding help themselves, and then also supporting those residents to take them to services until they feel confident and resilient in doing that themselves. We recognised as part of our transformation that we can't transform the system without really focusing on our children and young people, because we need to start to turn the tap off at future needs in the years. This is just a quick diagram for you. We've implemented a whole model of transformation. So the green bit is more our community and universal services. The bit in the middle, 4 early help locality teams that bring together, it's got a small enabling team, but really do bring together the vast raft of professionals in each of those localities, health visitors, school nurses, your children's centres, your schools, youth workers, police, etc., to provide a really comprehensive early help offer. And then a step up into a complex early help and safeguarding hub, which is built on our existing safeguarding hub to make sure that the police, mental health practitioners, adult services, as well as social care are in there that can provide an all-round risk management assessment. The ultimate aim of this is to keep children out of the social care system ultimately and to avoid them becoming looked after, but also with the focus, the second element, paediatric nurse practitioners, on keeping children out of the hospital system. Big element of this is to change the culture and practice of the workforce, because we think that's where the biggest change is, to really avoid some of the handoffs that happen in the system now, so people are spotting a problem and acting on it rather than referring it on through the system. Some early impact, the locality teams we launched them in January, really got up and running from April, but some really encouraging signs. So the figures speak for themselves really. So we're using early help assessments as a real key indicator to how we're identifying children's needs much more easily. So the figures there to April to August this year, doubling the number of early help assessments that we managed to achieve last year, and significantly more than the numbers that we achieved the year before. We're not quite yet seeing that reducing in contacts into social care, and we're doing some work to start to track these children now to see what else we need to do. In terms of A&E, our paediatric nurse practitioners are hooked into each of the early help locality hubs, so they can really use that intelligence, find out the frequent flyers and get some information off the ground so we can do targeted interventions with those people. Really encouraging this. I mean, it's small, but in terms of our A&E attendances for this cohort in the last year, there was only a 1% rise. It's a rise, but it's almost a plateauing, and it was the smallest rise in A&E attendances for any of our age cohorts in the borough, which again is really encouraging. Just up there, this is, as I said at the beginning, a lot of it is around the softer impact and the culture and behaviour of the workforce. And these are just a couple of quotes that you can read for yourself, with some feedback that we're getting from professionals, from schools and our school nursing, around how it's starting to feel differently and how practitioners really feel they're being able to make a real difference. That's it in a nutshell. I said it'd be quick.
Thank you very much, and interesting what similarities there were with what you were saying and what Donna was saying earlier. Okay, any comments or questions on the excellent work being done here in Rochdale? I think we'll be exhausted. Thank you again for the presentation and congratulations on what you're doing. The final item is to note the date of the next meeting, which is the 9th of November, but In doing so, I need to point out that one of our members, Stuart North, won't be able to be at that meeting because by then he'll have retired. Stuart's been active really since devolution began, in fact really before devolution began. He's put a lot of work in to attend lots of meetings, and I think we should record, Stuart, our appreciation of your contribution to GM devolution and wish you well in your retirement.